I'm John Strum, and this is Real Talk MS. It's July 13th, and we have a lot to talk about. Last September, 8,000 MS research scientists and clinicians gathered virtually for the joint meeting of the European Committee for Treatment and Research in Multiple Sclerosis and the Americas Committee for Treatment and Research in Multiple Sclerosis. Known as MS Virtual 2020, the largest MS conference in the world got underway with what I found to be the most compelling presentation of the entire event. It was a presentation on the Ms Prodrome by Dr. Helen Tremlett, a professor and Canada Research Chair in Neuroepidemiology and Multiple Sclerosis at the University of British Columbia. Now, the word prodrome actually comes from the Greek word prodromos, which means running before. And in medicine, a prodrome is a sign or symptom or a set of signs or symptoms that indicate the onset of a disease before diagnostically specific symptoms develop. And I remember that Dr. Tremlett concluded her presentation at MS Virtual 2020 saying, "It is time that the prodromal phase of multiple sclerosis is recognized." And just a few weeks ago, the MS Society of Canada partnered with the National MS Society in convening a virtual workshop focused on the multiple sclerosis prodrome. The workshop was titled Prodromal Multiple Sclerosis: Gaps, Opportunities, and Priorities. It was co-chaired by Dr. Helen Tremlett, and the workshop participants included some of the leading MS research scientists in the world. Dr. Tremlett is returning to Real Talk MS today to help us better understand what the MS Prodrome is and how understanding the prodrome can fundamentally change the way that MS is diagnosed and treated. It's a game changer. But before we get to my conversation with Dr. Helen Tremlett, there are a few other things that you should know about. When it comes to prescribing a disease-modifying therapy, doctors choose one of two different treatment strategies. They can adopt an escalation strategy, where a patient diagnosed with MS is started on a very safe, moderately effective disease-modifying therapy like Copaxone or Aubagio, and they only escalate to a stronger therapy when the current therapy seems to no longer be working for them. Or they can be more aggressive in their treatment and adopt an induction strategy, where a patient starts off with a powerful, high-efficacy disease-modifying therapy like Tysabri, Lemtrada, Ocrevus, or Gilenya, and these are therapies that carry a greater risk of side effects. In last week's episode of Real Talk MS, I shared the results of a study that showed people with relapsing remitting MS who received early induction therapy, receiving a high-efficacy disease-modifying therapy, experienced less long-term disability accumulation than people with relapsing remitting MS who received early treatment with moderately effective, lower-risk disease-modifying therapies, or the escalation treatment strategy. But what about people with secondary progressive MS? Well, a separate 10-year study investigated the effectiveness of high-efficacy and low-efficacy disease-modifying therapies in people with active and inactive secondary progressive MS. And the just-published study results indicate that the high-efficacy therapies were more effective at reducing relapse activity, but there was no difference between the high-efficacy and low-efficacy disease-modifying therapies when it came to limiting MS progression. 1,000 people with secondary progressive MS were recruited for this study, and the study participants received treatment with either high-efficacy disease-modifying therapies or low-efficacy disease-modifying therapies. The results showed that people with active secondary progressive MS, defined as experiencing a relapse within the past 2 years, they experienced 30% fewer relapses compared to those study participants who were given low-efficacy disease-modifying therapies. However, there was no difference in relapse frequency between the high-efficacy and low-efficacy treatment groups in people with inactive secondary progressive MS, nor was there any difference between either group when it came to slowing disability progression. Now, the research team pointed out that they didn't study each medicine separately, and each medicine could affect symptoms and disability progression differently. So clearly, there's more work to be done here. Future research will have to determine how each of these therapies is going to affect relapse rates and disability progression in people living with active and inactive secondary progressive MS. And if you'd like to review the details of this study, you'll find a link in today's show notes. A study analyzed the first visit to a neurologist by 8,744 people living with MS in the United States. Among them, 1,214 identified as Black and 7,530 identified as white. And the research team found that Black people have more severe disease and greater disability at their first visit compared to white people, even when differences in socioeconomic status are taken into account. The research team analyzed several measures of neurological health that are typically used to evaluate someone diagnosed with MS, and they found that at the time of their first visit, Black people with MS had lower scores when it came to walking speed, manual dexterity, and cognitive processing speed. MRI scans also showed that Black people with MS had more lesions and increased brain tissue damage compared to white people. Now, what still isn't known is whether these differences are due to disease-related factors, quality of care, or something else. Previous research has shown that Black people living with MS experience more frequent relapses, greater disability, greater mobility-related challenges earlier in the disease course, and some of the B-cell depleting disease-modifying therapies aren't as effective in treating Black people as they are treating white people. So lots more studies required here to gain a real understanding of why this greater burden of MS seems to impact Black people, and then the most effective treatment strategies can be adopted. But all of this calls for greater diversity in MS clinical research, and that's something that all of the major pharmaceutical companies are aggressively pursuing. If you'd like to review the details of this study, you'll find a link in today's show notes. And if you'd like to learn more about the challenges and experiences of Black people living with MS, you might want to put the Black MS Experience Summit on your calendar. It's taking place September 22nd and 23rd, and we'll be sure to let you know when registration opens up. The U.S. Food and Drug Administration has given its approval to 2 Phase 3 clinical trials of vidofludimus calcium, an investigational medication known as IMU-838. 2 identical Phase 3 trials were approved because one will measure the efficacy of IMU-838 in people with relapsing remitting MS, and the other study will measure the drug's efficacy among people with primary progressive MS and secondary progressive MS. The 2 clinical trials will be conducted in more than 100 sites in 14 different countries, including the United States, Latin America, Central and Eastern Europe, and India. Each trial will recruit about 1,050 people living with MS, who will randomly be assigned to a group receiving a 30 milligram dose of IMU-838, or a group receiving a placebo, taken once a day orally for 72 weeks. The main goal of the trial is to determine whether IMU-838 is more effective than a placebo at delaying the time to a first MS relapse. Disability progression, changes in cognition, brain lesions, and brain volume will also be assessed. Now, IMU-838 is designed to block the metabolism of active T cells and B cells. Now, these are the cells that drive the inflammation that causes damage to the central nervous system in MS. The idea is that by only targeting cells that are actively participating in inflammation, the medication won't affect the other parts of the immune system that defend against infection. Recruiting for these clinical trials is expected to begin later this year. Sativex is a cannabis spray that combines CBD or cannabidiol with THC, the main psychoactive ingredient in cannabis. It's currently approved and available for treating MS-related spasticity in 25 countries, including the UK and Canada. And there's a phase 3 clinical trial currently underway in the United States to measure its efficacy. Results from a small study in Belgium were recently published, and in this study, 238 people with MS used Sativex several times a day for 12 weeks. During the study, the participants' spasticity pain level was measured, along with their self-reported quality of life rating. And the outcome of the study showed that 60% of the participants experienced clinically relevant improvement in both spasticity and their quality of life, and chose to continue treatment after the 12-week study had concluded. Now, since marijuana can impair memory and processing speed, one of the things that the U.S. clinical trials will be looking at is whether Sativex affects cognitive function. We'll be sure to share information about the Sativex clinical trials in the U.S. as that information becomes available. And if you'd like to review the details of the Belgian study, you'll find a link in today's show notes. Elizabeth Jamieson is an amazing artist whose work reflects the intersection of art and science. After being diagnosed with multiple sclerosis, Elizabeth began transforming her brain MRI scans into remarkable and provocative images that challenge how we view the brain, disability, and illness. Elizabeth's work is part of the permanent collections at the National Institutes of Health, the Multiple Sclerosis Center at Yale University, the Shepherd Center in Atlanta, the John Paul II MS Rehabilitation Center in Poland, the Center for Brain Science at Harvard University, the MS Clinic at the University of California, San Francisco, and many, many more venues throughout the world. Since joining me as a guest back on episode number 48 of Real Talk MS, Elizabeth and I have not only stayed in touch, but we've become friends. And one of Elizabeth's longtime goals has been to create a space where people could have informal yet intimate talks around the kitchen table about the good, bad, and messy parts of daily life living with MS. These conversations wouldn't include so-called experts, just honest, unfiltered, raw discussions designed to provide a sense of community and camaraderie among people with MS. Well, that goal has been achieved with the launch of MS Confidential, a monthly web series that debuted last month and delivers on its promise of candid conversations on navigating the chaos of MS. The series features Elizabeth along with 3 other individuals living with various stages of MS. I hope you make time to check out this series. I found the first episode incredibly authentic and compelling. Episode 1 of MS Confidential is available now on YouTube, and you'll find that link in today's show notes, and Episode 2 airs live tomorrow, July 14th. You'll also find a link to that episode as well. Watching these 4 individuals speak their truths about the good, bad, and messy parts of daily life living with MS underscores some of the ways that MS changes people's lives. Being able to identify someone who is likely going to develop MS and proactively treating them so they never experience any symptoms could be equally life-changing. And that's a big reason why recognizing the prodromal phase of MS is so important. In a moment, we'll meet my guest, Dr. Helen Tremlett, who's leading the charge among MS research scientists to better understand the MS prodrome. Just a few weeks ago, the MS Society of Canada partnered with the National MS Society in convening a virtual workshop focused on the multiple sclerosis prodrome. The workshop was titled Prodromal Multiple Sclerosis, Gaps, Opportunities, and Priorities. It was co-chaired by Dr. Helen Tremlett, and the workshop participants included some of the leading MS research scientists in the world. Dr. Tremlett is a professor and the Canada Research Chair in Neuroepidemiology and Multiple Sclerosis at the University of British Columbia. Throwing in my 2 cents, it's my belief that increasing our understanding of the prodromal phase of MS could lead to proactive treatments that may prevent the symptoms of MS from even developing. That might not be a cure in the purest definition of the word, but it would certainly feel like a cure if you could live your life while avoiding the sometimes debilitating symptoms that MS can bring. It feels like it's been a while, but I'm happy to say that Dr. Helen Tremlett is returning to Real Talk MS to help us better understand what the MS Prodrome is and why it's important. Welcome back to the podcast, Dr. Tremlett.
Thank you very much. It's fabulous to be here.
So to get started, maybe definitions in order. In medicine, what do we mean when we talk about a prodrome?
Yeah, no, great question to start with. So a prodrome, say, can be defined as an early set of signs or symptoms indicating the onset of a disease or illness. So in the context of multiple sclerosis, think of that before our classical understanding of MS symptom onset, or put another way, in the years leading up to MS symptom onset. And obviously in an individual who's had the first symptoms of MS, they will subsequently go on to be diagnosed. We're not talking about just before diagnosis, we're talking about the years leading up to MS symptom onset.
We know that MS is defined as a demyelinating disease. And in fact, demyelination is what causes disability in MS. So would the prodromal phase of MS occur before demyelination occurs?
That's a very interesting question. Maybe the two occur at the same time. In short, we don't know the answer to that question. And that a little part of what the workshop was about was figuring out the things we do and don't know. We think that it's probably very likely that there's disease initiation. And let's even go back further in time. Perhaps you're exposed to some environmental risk factors that in a genetically susceptible individual, just for example, triggers the disease. Then you have disease initiation. Then one assumes the demyelination will perhaps start occurring around then, perhaps. Immune dysregulation, maybe axonal degeneration. Then at some point, we think that the symptoms will occur, which we're calling the prodrome. And then at some point, the individual will have a classic MS symptom onset. Let's say that could be optic neuritis. And let's say that could trigger them being referred to a neurologist. And that may ultimately end up in a diagnosis of multiple sclerosis.
I found this information to be particularly fascinating. I'm hoping you can share some of the signs or symptoms that you've identified that might potentially be part of the MS prodrome, or at least suggest that something's going on there.
Yeah, no, great question. And first of all, I'll just back up and say it's really interesting that the existence of the MS prodrome was largely dismissed in the early MS literature. You know, I went back and dug up some old MS textbooks, and they explicitly stated, this is dating from, it was current through until 2000, McAlpine's multiple sclerosis explicitly stated that the initial episode of MS is not preceded by any recognizable prodrome. So didn't exist, which is a shame, because in other neurological diseases, say Parkinson, it was already in the 80s, they were already examining and exploring the prodromal phase in Parkinson's disease. And they're well ahead of us now with criteria to identify people with prodromal Parkinson's. So essentially, my team went in and we wanted to really objectively measure the MS prodrome, because we knew if we walked into a room of, and I've had the privilege of walking into a room of, say, people with multiple sclerosis at some MS Society events, and when I explain what the prodrome is, and I ask them, do you recall, if you think back, do you recall having any prodromal symptoms? They will all come up with answers and symptoms that they experienced. And that's really powerful to inform us as researchers that this is an important question, but we needed objective information rather than people recalling past events. So what we did in Canada, we accessed health service utilization data. Essentially, we can get access to every single hospitalization, physician visit, or prescription filled by people with and without MS. And we could observe that in the 5 years leading up to MS symptom onset, we could see that as you got closer to MS symptom onset, the number of hospitalizations and physician visits and prescriptions filled really started to escalate, started to increase in our MS population relative to a matched general population not known to have multiple sclerosis. So we were seeing higher health service use, and that was published back in 2017 in Lancet Neurology. And then, of course, our second question is, okay, interesting, but why, right? Why are people accessing the health system? Which comes back to your question of what were the signs and symptoms. And this is where it gets really interesting. And it's potentially a very long answer. So because we found a lot of signs and symptoms ongoing in that 5-year period before MS symptom onset, we could find, for example, quite a high mental health burden. So we could find 50% more visits to psychiatrists in the 5 years before MS symptom onset, and 50% more visits to physicians in general, that resulted in what we call a diagnostic code for depression or anxiety or related. We found irritable bowel syndrome, more visits related to sleep disturbances, headache, migraine, pain. We found more visits to urologists, and we found other pain-related issues such as fibromyalgia. And the list goes on, but perhaps I'll stop there.
I'm just considering the fact that you've been able to isolate those signs and symptoms and the numbers. Well, they sort of speak for themselves.
I should say I think it's a very powerful way of looking at this question of the MS prodrome, because it is objective information, not hopefully not influenced by recall bias. But that said, everyone will know it doesn't capture everything, because not every sign and symptom an individual will have will result in someone accessing the health system. So that's the pros and cons of that approach. It's very objective, but it only captures people who visited their physician or access the health system for that issue.
When I introduced you, I mentioned that you recently co-chaired this workshop presented by the MS Society of Canada and the National MS Society, titled Prodromal Multiple Sclerosis, Gaps, Opportunities, and Priorities. I think you've actually started to answer this question already, but I'm wondering if you could share what were the goals of the workshop and what sorts of things were discussed.
Great question. So we had a vision of getting together a group of international experts and people like yourself to talk about the MS prodrome and consider what evidence there is available, what are the potential features, and obviously we've just covered some of those now. And then essentially, what can the field do with that information? What can we do? And I can jump to the what we can do piece now if you like.
Well, that's fine. You knew that was coming up for sure, but please feel free to jump.
So I guess, as you alluded to at the very beginning, it definitely the existence of the MS prodrome definitely has implications for early recognition of multiple sclerosis. So it suggests that we could actually recognize, maybe even diagnose MS earlier, and maybe then we could manage MS earlier as well. That is a lofty goal. That we're still some way off from doing that, but that is a long-term goal. For example, if you look at other neurological conditions or other immune-mediated conditions. So just let's take Parkinson's, for example. They actually have validated criteria to identify people in the prodromal phase of Parkinson's disease. So perhaps ultimately, if we could develop such a criteria for MS, maybe you could offer people enrollment in a trial of a neuroprotective agent, assuming we would have one that would be worth offering to people. So that is a long-term goal. But what we can actually do with the prodrome right now, or what we know about the prodrome, and I think this is really important, if it has implications for prevention of MS. So if you want to know what causes multiple sclerosis, you have to consider very carefully this prodromal phase when you're looking for risk factors for what causes or triggers MS. You want to be very careful that you don't measure something going on in the prodrome and assume that causes MS when these people probably are already on that trajectory to develop MS. Does that make sense?
Completely. Well, I found the workshop to be fascinating. As I mentioned to you when we were offline, I am really interested in this particular aspect of research. So I appreciate the work that you're doing. I think it can benefit people who will be living with MS in countless important ways. I'll add that for me, your presentation on the MS Prodrome was the highlight of last year's MS Virtual 2020 conference. And I remember you concluded that presentation by saying, "It is time that the prodromal phase of multiple sclerosis be recognized." So my question is, what should happen next to make that a reality?
That's a great question. And I have to say, it was really a real privilege to be asked to present as the opening speaker at that conference. And they did specifically ask me to talk about the prodrome, which I think to me highlights the interest in this area. So where next? I think you will have heard from the workshop that we identified a lot of gaps and opportunities as well. There's a lot of things we still don't understand and we don't have a good grasp on. So what we're currently doing at the moment is drafting up a paper based on the workshop, which will highlight what our kind of gaps and opportunities are and how to pave the way forward, what additional research needs to be done to, for example, initiate creating these criteria to identify people in the prodromal phase of MS. So that is work in progress. I would love to come back in 6 to 12 months and tell you when that's published and give you the highlights.
Well, you can be assured you'll be receiving an invitation to do exactly that. I'm looking forward to seeing that paper published, seeing the MS research community as a whole respond to the call to action that that paper is going to represent. So I'll be looking forward to seeing that publication. Dr. Helen Tremlett, I want to thank you for all that you do to improve the lives of people living with MS today and perhaps improve the lives of people who have yet to be diagnosed with MS. Thank you for all of your work, and thanks for talking with me today.
And thanks for your podcast. I think it's fabulous. I know I told you at the beginning, I listen to it as I run around Vancouver's Stanley Park seawall in the morning, and it's great. So thank you.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society. And you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/202. You'll find that link in today's show notes so you can easily copy and paste it right into an email or text. If you haven't done so yet, please don't forget to visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the easiest way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to save your favorite episodes, and it's a great way for me to share bonus content with you. So I hope you'll take a moment and download the app today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.